Hey everybody, Mr. Toady here. Welcome back to another flipped lesson. And in this lesson, we're going to be talking about spine, brain, and nervous system injuries, which is really kind of the next step after we talked about musculoskeletal trauma. And really, really important because these are three really important organs vital to us maintaining homeostasis. So if you injure these and if we don't treat them appropriately and quickly, we could have some really long-standing effects that could really kill someone or affect their lives forever. So really important stuff in this lesson. Here's just some of the objectives here. And if you want to take a screenshot, this is kind of what we're aiming for to get over by the end of this lesson. And of course, there's going to be more key terms that go along with it. So at the end of the video, go back, make sure you get all of them and you understand any that you see here. All right, so we're going to start off talking about some anatomy and physiology first, because it is really important. And these are things that we need to know as EMS providers and really anybody that's going to be working in an emergency medicine field, right? We know we have the axial, the appendicular skeleton. So we're really talking about the axial skeleton, right? Skull, vertebrae, ribs, and sternum here. And when we're talking, we'll start with the spine here, right? Especially in the spine, we have 33 vertebrae, which are the individual bones that make up your entire spinal column, all right? And we have different regions of these, okay? So it's really important we know that because when we're assessing a patient for different types of injuries, we need to be able to identify where it is to pass it on to the hospital so they know what they're looking at. So you have, starting from superior working way inferior, cervical, thoracic, lumbar, sacrum, and coccyx, all right? And a great way to remember, especially the first big three, is, well, what time do you eat breakfast, lunch, and dinner? You eat breakfast at 7, lunch at 12, dinner at 5. And maybe if you add these together, you get 9. You eat dessert at 9 o'clock, right? So our cervical spine, right, is our neck, and there's 7 vertebrae there. And these are really, really crucial. And to be honest, those are really probably the most important vertebrae that we're concerned about in some kind of neck or back injury, because crucial functions come out of the nerves that come out of those vertebrae. I'm not saying the other vertebrae aren't important or that they can't get damaged, but these are really our critical ones for life saving, maybe not life saving, but life sustaining functions, right? Breathing, blood pressure, heart rate, all have to do with these nerves here. Okay, so 7 there. Our thoracic region, 12, and that's where our ribs connect to. So we would see ribs coming off these. Our lumbar, 5, and you can see they're really, really huge compared to the other ones because they bear a lot of our weight. And we can actually injure these pretty easily, especially from lifting the wrong way, from getting hit back there. Very painful if you get hit there. Our sacrum, right, this is where they're actually fused together here. They're not individual like the rest of the vertebrae are. And then the coccyx, right, the tailbone. And you'd be surprised, we actually see a lot of coccyx injuries out there, all right? A lot of people that break tailbones just from falling on their butt. It happens, all right? So the bones are really important of the spine that we need to know. And of course, what are they attached to? One big old, well, it's actually multiple bones fused together, right? The cranium or the skull up here, which houses the control center, the brain, all right? And I mean, we could spend a whole semester just talking about the brain, its functions, what happens in different areas. If we need to really boil it down for one flipped lesson for emergency medicine, we need to think about the things that keep us alive. And I kind of just referenced them before. So heart rate, blood pressure, breathing, right? All of our vital functions. Like, it's great to be able to have a frontal lobe and to think and make decisions. But without the medulla oblongata and the top of the spinal cord here, we're not going to be alive. So we can't even have that higher order thinking that would happen in the cerebrum or the muscle movement that would occur from the cerebellum. All right. So we're really thinking about vital life sustaining functions. And that's all in the brain that is in the skull, the cranium, which are bones that are fused together. When we talk about our central nervous system, it has 2 components we kind of just referenced. All right. We have the brain, the control center, and the spinal cord, right? So the spinal cord is a cord of nervous tissue, like a big old neuron, that runs through the middle of your vertebrae here. So it's protected by these bones. It runs inside of them, all right? And while the brain controls our body, it comes up with, controls the functions, our life-sustaining functions. How do we get those signals out so our body listens to it? Well, it's through the spinal cord that comes through here. All right. And we can see this is a great picture because what runs out of the spinal cord is our spinal nerves. And these are really crucial. And you can see these top ones here are cervical nerves through cervical bones 1 through 5, really control some of those really important things like breathing. Okay. But even more important down below those, not to say that thoracic or lumbar injuries are no big deal, because they can be, right? Our spinal cord runs all the way down here, and we have nerves coming all the way out. So just thinking about, and we'll talk about this in a few minutes, right? If we were to injure our spine, our vertebrae there, and injure that spinal cord, really serious, because we could have things resulting in paralysis, all right? Well, again, obviously, if we injure the brain, we could stop breathing and doing important things like that. But even if we injure the upper cervical vertebrae and the spinal cord up here, that could be deadly as well. Not just paralyzing, but deadly. All right. Really, another important thing here, which we're going to talk about, is so not only does our central nervous system have the brain and spinal cord, it has a fluid, right, that's actually soaking all of this and kind of cushioning it and protect it. Just like how a baby floats in amniotic fluid, all right, to protect it, our brain and spinal cord are soaked by that CSF, we're going to abbreviate it as, or cerebrospinal fluid, which protects it, okay? And we have our peripheral nervous system, or think about the outside, your peripheries, right? Nerves that connect the rest of the body to the spinal cord. So all in all, I've said it a bunch of times here, if you couldn't guess already, this is why this is such an important chapter for, especially when we're studying trauma and how it affects the human body, because if we damage our brain or our spinal cord or our skull and vertebrae, right, that can have long-lasting effects. So it's really important we know this anatomy, we know where everything is, we know how it all plays into the human body. All right. So we're going to look at some different types of injuries. We're going to kind of break it. We'll work our way down here. So let's start with like head injuries and soft tissue injuries. And just remember, keep in mind that all of these could be really deadly or painful or damaging lifelong disabilities, right? We think about that ABCD in our patient assessment. So, all right, two kind of injuries to our brain and spinal cord, kind of just like we talked about soft tissue injuries, right? We could have open and closed. Well, we can have open and closed central nervous system injuries, all right? And I would argue 95% of these injuries are closed, all right? We generally will not see brain or spinal cord. I know in my career, I've only seen it once. So it's really severe trauma that we have to see this here. All right. But what are some of those that are going to look like? Well, probably for especially head injuries, it's going to be some sort of skull fracture. And you can see some different pictures up here, these cartoons, and then we'll talk about these in a second here. But literally we fracture or break that's the skull that surrounds our brain, right? The cranium here. And you can see there's usually going to be a soft spot or a depression. So again, when we're doing our secondary assessment, we're doing our physical exam, we're palpating, you actually might feel it move in, right? If you touch your skull right now, mine's harder probably than most of yours, but it's nice and hard. If you feel it moving, that's not good, okay? Something else we might see is, and not only moving, right, for a soft spot, but a depression. So it may not move, but you may go around and feel a little divot there, kind of like you could see in figure B. That's really not good. That's a serious trauma. We need to get that looked at. Something else we're looking for is this cerebrospinal fluid, right? CSF is leaking, all right? Where do you think we might see that leaking? Tell your answer right now out loud. Dora the Explorer, Blue's Clues style, right? Yeah, we might see it coming out of the nose or out of the ears especially. If we fracture that skull or vertebrae to the spinal cord hard enough, that CSF could leak out. And one way to see that here, and you can see that there's a drop here on this gauze next to this guy's ear, you can see he's in a C-collar, so some kind of head injury. And this is zoomed up, and we have what's called a halo effect. So if there is cerebrospinal fluid leaking, obviously there's always going to be blood whenever we have an open injury. But you'll see here, it's not just a regular drop of blood. You have like this halo or like these concentric rings. So you see white, then some blood, then some white, this halo, then another line, then some white. All right, that's kind of that cerebrospinal fluid separating out from that blood. So they call that a halo effect, which you would see when the cerebrospinal fluid is leaking from some type of injury. Okay, so bruising, Or ecchymosis could be another sign. We have raccoon eyes, right? If you've ever seen somebody get a black eye, a hockey player, something like that, a boxer, doesn't always mean they have skull fracture, but it is a good sign, especially this patient up here. You can see these really dark bruising. Obviously, a skull fracture, probably up in the orbitals or someplace up here near the nose. All right. And then we have what's called battle signs. All right. And this is actually a really serious one to look for, too, which is behind the ears. All right. You can see right here, there's some black and blue bruising behind the ears. That's going to be the sign of a basal skull fracture, right? Someplace back here. And then obviously exposed brain tissue. If you could see brain, that is not good. Okay. That's going to be an obvious sign of soft tissue injury. All right. So that's kind of our thing about like our soft tissue, our trauma, right? We might see things open, but I would actually argue, I mean, you're going to see a lot of that. And like I said, you really won't see a ton of open injuries where a patient survives. But when we think about our head injuries, right? Most of them we said are closed, and most of them really affect the brain, not just the skull and the soft tissue surrounding it. And it's really, really important stuff because without our brain, I mean, what are we? We're just a pile of mushy muscles and bones, right? But really big in the news, right? Especially think about sports, high school sports, professional sports, the big word, the C word, concussions, right? But what worries me, and you'll see me at the athletics game sometimes, right, helping out, but I'm not so much, I mean, I'm worried about concussions. They're a serious thing. I'm worried about even worse type of brain injuries that we'll talk about. All right. But first we need to talk about like what happens when you hit your head really hard. And we have what's called a coup contra coup, or coup, I always say coup, brain injury. All right. And that's caused by rapid deceleration of the head. This guy is, whoever drew this, I mean, his face is just something else right here. All right. But coup contra coup basically means you're going really, really fast and you stop, boom. So your brain hits forward. But then when you stop short, you actually go back too. If you've ever seen those slow motion videos of car crashes with test dummies, right? They go forward, hit the airbag, but then they bounce back just as hard. And this is not just car accidents. This is any serious deceleration. So if you are a soccer player and you're running head first and bam, you smack into another player. If you're riding your bike and you go flying off and bang, hit a telephone pole, right? Any type of deceleration, your brain, and this is a great picture down here, right? We see the brain going forward, it strikes the front of the skull, and then it actually goes backwards and hits the back of the skull. It kind of bounces inside your skull because your brain is not a tight fit. There's some space there. So that's that coup contra coup, which is really, really, it can be very deadly, all right? It can really damage the brain, rattling it around in there. And what really worries us is swelling and bleeding from these events will create intracranial pressure, okay? Pressure within the skull. And again, your skull is by the time you're older, not so much when you're a little kid, but we said it's a bunch of bones fused together. So think about having like a water bottle, but only has one hole. And we know your skull really only has one hole, and that's at the bottom, the foramen magnum, right? Where the spinal cord comes out of and it attaches to your vertebrae here. So that's the only hole to come out, is where the spinal cord attaches to the brain. So we're going to talk about some of these issues that come with intracranial pressure in a minute here. But what do these brain injuries lead to, or what's the big category? Maybe you've heard of it, a TBI, a traumatic brain injury. So a mechanical injury to the brain that results in short and or long-term neurological deficit, okay? So TBI is a big category. It doesn't always mean a most serious thing. It could be as mild as a mild concussion, which we'll talk about. So I listed 4 here. We're going to talk about a couple. There's a ton of, there's like many, many different types and specifics of TBIs, traumatic brain injuries, but basically any injury that's caused to the brain from trauma. All right, so let's get into a few of these here. And remember, you got to remember that coup contra coup. That's what really causes these, that brain moving back and forth and hitting the front and back or side to side of the skull a couple times. All right. So first off, a concussion, right, is a traumatic brain injury caused by temporary disruption of coordinated brain function caused by trauma. And I put this here just because I know, like, we think about it at school all the time. Sports, right? Especially our football players, our hockey players, soccer players, any chance where there's physical activity. And maybe it's not even a high school sport. Again, maybe you're a big skateboarder, rollerblader, skier, right? Things we need to be really concerned about is getting a concussion. And right, in terms of our bad things that can happen when we hit our head, a concussion's actually lower on the list, right? Mild symptoms of a concussion would include dizziness, nausea, headache, vomiting, sensitivity to light, like the lights around me, loud noises, stuff that can really disrupt your everyday life. And I've had a few friends, including one that I'm married to, that had several, a concussion before. And I'll tell you what, it stinks. Like, you could have a concussion that can go away in a week and you feel better, and you can last 6 months, 8 months. You might have to see a specialist to help you resolve some of those symptoms. They could be really, really serious. Again, it all comes down to the amount of force when you got hit in the head or you had a deceleration and that coup contra coup. All right. So concussions, we're concerned about them because it's actually not really like, you have those symptoms that are detrimental to your life right then. If you can't look at especially right now in COVID, if you can't look at a computer screen without getting dizzy and throwing up and having a terrible headache, how can you get through life? So they are life altering, even though it may not have long term effects years down the road, but they can as well. And we think about our athletes, like boxers, right, or football players that constantly are getting their head hit and probably have way more concussions than they report. That can lead to CTE, right? That we know is the disease where comes from concussions from repeated head strikes that can really alter someone's mental state. All right, so there is a lot of long-term effects, and in our patient assessment, right, we're asking if you've had any recent head injuries, and if we are assessing a trauma patient that said, "Oh yeah, I got diagnosed with a concussion, a month ago," that's gonna put warning bells up in our head, because if you injured your brain recently, it's much easier to re-injure it and re-injure it worse with some of the things we'll talk about down here. So what's a sign or symptom that we might see with either concussions or some of these other more serious traumatic brain injuries? Something called amnesia. Maybe you've heard of amnesia before. It's when you forget things, all right? And there's two types of amnesia, retrograde and antegrade. So retro, think about like retro back in the day, right, is characterized by no recollection of the events prior to the injury itself. And I've seen both of these a bunch of times in patients. And this is when your patient's going to say, "Whoa, what happened? Wow, what happened?" And like literally every 5 minutes, right? Well, not every 5 minutes, but I take that back. They're going to say, "What happened?" And they're going to have no clue what happened. And they'll be kind of with it now. No idea what's going on. All right. That's that retrograde. They forget what happened before the injury. Versus antegrade amnesia, right? Characteristic by no recollection of events occurring after the injury. So they might remember what happened, but then 5 minutes later, they're going to say, "Hey, who are you? What's going on here? Why am I in the back of an ambulance?" And then you'll tell them, "Oh, my name's Chris. I'm with, Harvard EMS, and you took a 20-foot fall off a ladder." And then you finish your sentence. You go, "Hey, who are you? Why am I here? Why am I in this ambulance?" Right? They're forgetting things that happen afterwards. One of our good tests that we'll use, and again, there's so much I could never put all this in a flip lesson. You'd be sitting there for hours, right? But you ask them to remember a couple words, like easy words, right? Remember the number 3, pen, hat, Burlington. All right. If you can remember those 4 words, that's good. That means your brain's working. If you don't remember any of them, that's not good. Okay. So that's amnesia, right? Forgetting things, something we want to look out for not only concussion, but also for these. So I said, concussions are scary and they're not good, but what's way worse is if we have something called a hematoma. And if you remember from our patient assessment chapter, a hematoma is kind of like a big swelling, like almost bleeding, right? Internal bleeding. And this is really dangerous. We talked about in the last slide that intracranial pressure, right? Our skull is a fixed object, so our bone can't expand. But if it starts to fill up with blood, right, what's going to happen to the brain that's inside of there? Well, since the skull can't expand, it's going to stay the same shape. The brain is actually going to get squished by the bleeding. And eventually what's going to happen is the brain is going to get pushed out of the one hole going into your skull, the hole at the bottom of your skull, the foramen magnum, where your spinal cord is. And guess what? At the bottom of your brain is where right down here, right where the spinal cord comes in, is where the most basic body functions are controlled at the medulla oblongata, right? Heart rate, breathing, blood pressure. When that starts to get pushed out of the hole, guess what your body stops doing? Breathing, heart rate, blood pressure. Really, really serious stuff. So, two types of these hematomas that are really deadly, all right? And they have to do with, and I'm not going to get crazy into the anatomy here, but you have your brain, you have your skull, and then you have this connective membrane called the dura, right, which you can see right here in white, which is between your brain and your skull. It's kind of like a waxy kind of covering around your brain. So an epidural hematoma is a TBI that results in bleeding between the skull and the dura mater. All right. So we see epidural hematoma. We can see the dura mater right here, the white. This is bleeding that's outside. All right. And you can see what's it actually doing here? It's pushing the brain in. And this shows up on CAT scans, right, as this big white spot. Pretty obvious to see when you get a lot of bleeding. You can see there's a skull fracture. You can see where the bleeding is here. All right. Very, very dangerous. Your patient's going to crash pretty quickly with this. Start losing functions. The first thing, and we'll talk about assessment here on the next slide, but thinking about that mental status, they're going to go downhill real fast. And then you can see down here, right, here's the medulla oblongata, here's the spinal cord. That's going to start to get pushed down there. You're going to lose those functions. All right. The other type of, there is other ones, but the other one I'm going to talk, the other one I'm going to talk about is not an epidural hematoma, but a subdural. So that means below the dura. All right. And you can see right here some venous blood. Here's the dura mater, so it's below that, all right? And also very serious, very easy to die from. The scarier thing about these is that they can actually take a while, hours, sometimes even the next day to start really having their effect. So you might have a halfway decent fall, think nothing of it, 6 hours, be dead and not breathing, all right? So this is why we need to take head injuries really, really seriously, because in the field, and if there's one key thing to take from this, it's this, right? In the field, can we try and figure out the difference between a concussion and a more serious, like a brain bleed, one of these types of hematomas? We can, but the only way to really know is to do a CAT scan and get a picture of the brain and see. And guess what? I don't carry around a CAT scan in my pocket or in my ambulance. So trying to convince a patient to go and get checked out can be very tough. And it's unfortunate because we want to have the best outcomes for our patient. And we need to tell them, like, hey, this is the risk if you don't get checked out by a head injury. It could be deadly. And I'll tell a long story in 10 seconds here. I had a patient once who basically he had amnesia. He had retrograde, didn't remember what happened before he fell. Everything else was fine, just felt a little dizzy. We talked to him for 20 minutes before we finally convinced him that he should go to the hospital. Guess what? When we got there, turns out he had an epidural hematoma. They put him on a helicopter, flew him to a trauma center. If we did not convince him, he probably would have died on the way home. So really serious stuff here. Do not take head injuries lightly. All right, on a brighter note, let's talk about cervical spine fractures, right? So getting away from the brain a little bit, which we could talk about forever, like I said. Let's talk about this. And we can see here, here's our vertebrae, the bone. We see the posterior, the anterior, right? We see the cartilage discs here. But in the middle, you can see this awesome spinal cord here that runs through and the spinal nerves that come out that control everything. So spinal fractures are really dangerous as well because they can result in paralysis, right? Because that's our connection from our brain all the way down to the bottom. So if we sever it halfway down, we're going to lose all control below that. All right. And same thing, if you sever it high enough up in your cervical spine, you can become a quadriplegic, right? All four limbs. All right. This thing right here, C345, keep the diaphragm alive. So the diaphragm, the muscle down here that controls your breathing, comes out of C5. So if you break something above C5, C1, 2, 3, 4, 5, really dangerous. Okay. Direct injury to the spinal cord can be caused by that broken vertebrae, all right, which can actually cut the cord. And once we cut that cord, right now in our time, we have no way to repair that. You are going to be paralyzed or have the effects of whatever is below that cord missing for the rest of your life. And then indirect injury, similar to the brain bleeds we talked about, you can actually have pressure from a hematoma inside that spinal canal where the spinal cord runs here, which puts pressure on the spinal cord. Which is a big deal too. All right. And I guess I'll just say here before we get into the more EMS, bigger picture, right? In the field, there's nothing really we could do to treat that. All right. They need surgery. But for both, either if it's an indirect injury, pressure in the cord, or especially, right, one of these subdural bleeds, what they actually do is they just take a drill, drill a hole in there, start draining out that fluid, relieving the pressure. The key is they need to do that soon enough before you have permanent damage. All right. And that's how you get a steel plate in your head. Cool. All right, let's talk about EMS now, right? The patient assessment for evaluating these types of injuries. So I put it first here because it's most important, right? As you learn, as you're learning in class here, we're learning a lot of different skills and lots of knowledge. And this is just the EMT level. Imagine being paramedic, RN, MD, PA, whatever. So much to know, but what is the most important for everybody? Our ABCs, right? Our airway, breathing, circulation. Especially true with these patients because, like we said in the last slide, right, for any brain or spinal cord injury, anything down to cervical 5 is going to control your pulse, blood pressure, breathing, diaphragm. So these patients that have serious high spinal or brain injuries are at a serious risk for stopping breathing. All right, we need to be able to breathe for them, monitor their airway, keep it open, breathe, monitor their circulation. So, and when in doubt, ABCs, that's what it's all about. All right. In terms of assessing, though, these brain or spinal injuries, what are some other things we need to look for? So right off the bat, our AVPU, right, our level of responsiveness. So alert, verbal, responsive to pain, unresponsive. And again, think about, we talked about like those, whether it's a concussion or a brain bleed, a subdural or epidural hematoma, right? The patient might start trending down in mental status. Maybe they're a little confused, all right? They don't remember what happened. That would not be alert. That would be verbal, all right? And we didn't talk too much about the Glasgow Coma Scale, but that's a more in-depth one for level of responsiveness, all right? Asking those questions like, do you remember, right, person, place, time, and event, okay? Do you know who the president is? Do you know where you are? Tell me what happened. Monitoring if they start to have that amnesia and forgetting. Really important stuff here, okay? The next part here is assessing CMS we talked about last chapter, circulation, motor, and sensation in arms and legs. That's a good baseline for our whole spinal cord and brain, right? If you have good CMS in your arms, but not in your legs, that should be, or in your feet, I should say, right? Can you wiggle your toes? Can I feel a pulse? Can you feel me tapping? Can you push your feet against me? That's a big scary thought. All right. Same in our arms, right? Especially if we have a back injury and I say, hey, squeeze, I give them both my fingers, squeeze my fingers as hard as you can, and they can't squeeze them. That's something to take note. We need to get to a trauma center right away. All right. Assessing the pupils. I said this in patient assessment. The eyes are not only the windows to your soul, it's the window to the brain. All right. Looking at those pupils, right? By looking at them, that tells us what's going on with the optic nerve, what's going on with the brain. One of the first places we'll see something going wrong with a head injury patient is not only in their level of responsiveness, but also in their pupils. Are they reacting, right? Remember Pearl? Pupils equal and round react to light. Okay, and next thing here, which you can see my friend Dr. Yohi doing, is palpating the spine. So that's part of our assessment, right? Not only are we palpating the skull, right, and the front of the face and the jaw, we're doing the spine. So with 3 fingers, right, I like to walk my way, start right up here at C1, walk all the way down. You're feeling for anything that's not straight and in line as the spine should be. So anything crooked, you're feeling for anything crunchy, any crepitus, and you're feeling for any pain that the patient might have. If you're going down the spine and they go, oh, right, that's that. If they're conscious, that's a bad sign that they have pain directly on the spine. So also thinking about the mechanism of injury, all right? And we'll look at a slide here in a second, but how serious was this injury that caused them to get hurt? Did they get ejected out of a moving vehicle at 45 miles an hour? Chances are if they did, they could have really hurt something. Did they fall 15, 20 feet off a ladder? That's a serious mechanism injury. All right. And then something else to look for here is this thing called posturing. And if you see this posturing, that is a very serious brain injury, spinal cord injury. Chances are probably even fatal. And you can see 2 pictures over here. So this is an unconscious patient, all right? You could have decorticate or decerebate, all right? And decorticate is on the left, decerebate's on the right. So somebody's unconscious, their body is automatically, without them involuntarily, thinking about it, they are flexing. So decorticate, I think about protecting the cord, right? You're flexed in like this. That's very serious. Decerebit, you can see over here, they're flexing away. So I think about decorticate, protecting the cord. I'm fighting for my life. Decerebit, if we see that, that means their life is pretty much over. That's a sign of near death, okay? So posturing, we're looking for in an unconscious patient. Something else to think about, and maybe you've been reading this on the right here, okay, signs and symptoms of a TBI. And the first one there was unresponsiveness, okay? So there's lots of these. I'm not going to read all of them. Unresponsiveness, headache, nausea, altered mental status, loss of consciousness, dizziness, seizures, okay, incontinence, so going to the bathroom, paralysis. Well, guess what? A lot of these things, rise in blood pressure, not only could they be signs of a traumatic brain injury, but they can also mimic a lot of medical emergencies, right? Like someone who is hypoglycemic, has low blood sugar, might be altered mental status, might be nauseous. Did they just not eat anything and they're diabetic, or did they hit their head? How do we know? Because those are two very different things we're going to treat. Well, guess what? It comes back to our patient assessment. We need to be good investigators. We need to get a good history. We need to do good vital signs. We need to look around and size up the scene. That's where patient assessment, I was going to say fun because I do find it fun, but it's really serious because we need to be really good investigators and detectives to figure out what's going on and what caused this for the patient. All right. So just always keep your mind, was this medical or was this trauma? Or was it both? Were they hypoglycemic and then fell off a ladder? If so, then, you won the lottery there. And then finally, vital signs, right? Monitoring vital signs. The cat is just going to town back there. All right. Again, vital signs are going to help us trend the patient. Are they stable? Or are they going down? All right. Getting baseline vitals in every 5 minutes immediately afterwards. So how do we treat this in the field? So it's this idea of spinal motion restriction, or SMR. All right. And I actually took a screenshot from the MASS protocols here because I've said this in class, but this really has changed tremendously in the past 5 years. It used to be if anybody had any back pain, like, oh, my back hurt, we slapped them on a hard backboard, tied them down tight, and left them there for 2 hours while they're in the ER. Turns out that injured way more people than it actually hurt. Now, there's some people that definitely need that, but the majority do not, okay? So this is kind of out of, and I like this little flow chart. So when do we immobilize? So mechanism of injury, right? Blunt trauma, motor vehicle crash or bicycle, fall greater than 3 feet. That's it. If you fall more than 3 feet, or an adult fall from standing height. So you're standing and you fall down and hit your head. Okay, so if you're older than 65, yes, if any of those happen, you need to immobilize with a C-collar and SMR. Is the patient unreliable? That goes back to that mental status. So do they know person, place, time, event? Person, place, time, and event, right? If they don't know any of those or they're confused, yes, they need to be immobilized, because how do we know that they're not actually in pain? We can't, all right? Is there a distracting injury? So if their wrist is bent backwards and they're screaming, do you think they're going to be with it enough to be able to know what's going on and say, ooh, yeah, my neck really hurts and I fell 20 feet? No, right? So distracting injury, yes, immobilize. Abnormal sensory exam. So when I did my palpations and did I do my CMS and fit hands and feet, right? If they couldn't wiggle their fingers or toes, they had no, right? That if any of that is weird, if it's abnormal, yes, immobilize. If they have spine pain, right, directly on the spine, yes, immobilize. If none of these are true, then it's okay to not immobilize the patient. Just have them sit on the stretcher, all right? So when we're doing SMR, a cervical collar is required, all right? And we always want to try and protect the spine. So again, it used to be this big thing. We still want to be careful. We never want to move a patient side to side. We always want to move them up and down in line with the spine. We don't want them to say, if I say, oh, do you take any medications? And they go, no, right? We don't want them to move their head like that. So we're still going to hold C-spine precautions with our hands. Our partner will hold them, their head steady. We're still going to put a collar on. We're still going to put them nice on the comfy cot, strap them down so they really don't move. But we're not going to strap them to that hard backboard most of the time, okay? So fill voids, pad, etc. So what can we use to do the spinal motion restriction? And I will say this is going to change depending on where, I'll put myself right here, on where you are practicing state by state, but almost every state has gone the way of using the ambulance stretcher here. And you can see this woman, she's sitting up. She's got a C collar on. She probably had something that met that criteria, right? Maybe she was unreliable. Maybe she was drunk and she got into a car accident, or maybe she had altered mental status, or maybe she had pain on the spine. But she's strapped into the gurney and she's not straight down. I probably would bend her down a little bit more, but she's got a collar on. She's strapped in, immobilized. That's that. So what else can we use? A full body vacuum splint like this one right here. Those are really cool because you kind of just fold them around to the form of the patient. So the patient gets like a nice comfy sock around them. You suck the air out and it keeps them from moving, but it doesn't pin them down tight to a flat board. All right, the scoop stretcher, we see that down here. We talked about that as a tool. That's a great tool for, I guess we could immobilize them to that for the whole ride, but we scoop them up and then we could put them on this ambulance stretcher. Great tool for that. And then finally, the traditional backboard or the long backboard or spine board we could see here. We're really not using these as much as we used to. It doesn't mean we can't. I'm a big proponent of using these the right time, the right place, especially for extrication. But you can see here, this person's strapped down, really tight, can't move to a hard flat board. You can see where that can cause some injuries. However, we can still use these if we want to get a patient on here, log roll them on, and then pick them up. And let's say we have to carry them out of the woods or out of their car and then put them on an ambulance stretcher. We could definitely do that. All right. So some different ways for SMR here. The big thing is we're trying to keep the patient comfortable, but not moving at all while having a C collar on. And again, checking those distal CMS, right? I'm thinking about those really serious trauma patients that we're talking about, exposed brain to quarter-bit to cerebit posturing, not breathing. We're probably just going to have them on a backboard or on a scoop and not take them off because it's a lot easier to manage them, roll them over if we have to for airway control. It's cool. So, hey guys, I know that was a really long lesson, but I think, like I said, this is a really important chapter because out of all the trauma, this is some really serious stuff. So make sure you go back, got anything in your notes there that you may have missed. And hey, stay tuned. We'll see you on the next one. Be healthy.